All right, let's get started. This is Carol from the Society of Thoracic Surgeons. This is the Adult Cardiac Surgery Database User Group call for September 21st, 2022. Can you all see, Leanne, can you see my slides okay?
I see them.
Okay, thank you. So on the call with me from STS, we have Leanne Jones, Emily Conrad, Melinda, and Sydney Clinton. We have from IQVIA, we have Jean, Joe, and Steve. There is no IQVIA update today. And then we have a special guest with us, Susan Wagner, and two of her colleagues, Alina, sorry, I'm not saying your name correctly, and Caddy from Stanford, who's giving us a presentation today on how they improved their perfusion data abstraction process at their hospitals. So we're going to go ahead and get started. This is Hank enjoying one of the last summer nights that we have he had a busy day at work last Thursday, and his little sleeping mask on. So we'll go through the important updates, and then we'll hand it over to Susan Wagner for her presentation, and then open Q&A. Today is September 21st. This is the Adult Cardiac User Group call. Next call will be the monthly webinar on October 5th. And then we'll be an AQO October 26th through the 28th. October 27th is the day dedicated to adult cardiac. November 16th is the user group call at 2 p.m. And then November 18th, Harvest 4 closes, which will contain OR dates through September 30th, 2022. Just a quick update on quick screenshot of the harvest dates. There's no changes here. Harvest 3 is an analysis. Probably expecting it back from DCRI to IQVIA right around AQO time, and we hope to have it available shortly after AQO on the platform. That will be the next star rating. The September training manual is posted, and then AQO registration is open. And we have a nice group so far that's coming in person. Hopefully if you haven't registered yet, you'll be able to join us in Rhode Island this year. It is October 26th through the 28th. Early bird closed on August 26th, so we're at the standard rates. The most data managers are non-members, so it's a $750 fee for one track, and the prices are here. And here's the difference between the in-person and virtual pass. The virtual pass will not have any live streaming with it, so you will have access to the on-demand content mid-October pre-AQO with the in-person attendees, and the virtual attendees will have access to any on-demand content prior to AQO. And then you will have access, if you decide that you can only attend virtually, you will have access to the recorded in-person sessions available in mid-November. Oopsie. Make sure you book your rooms by Tuesday, October 4th to get the rate. Melinda shared with us on our last call that there is a military rate. If you book your room under the military rate, which I hear is less expensive than the AQO rate, please let us know that you booked your room so that we can meet our reservation requirements with the hotel. And then just preliminary topics, we'll talk about the aortic valve with annular enlargements, mitral valve procedures, CABG anastomoses, VAD, ECMO, and Impellas, database and value-based care, how that's being used how databases are being used to develop governmental payment systems. We'll have a presentation on the TVT registry, and then a cath echo hemodynamic presentation. We are going green this year, so if you need to print any data collection forms out with you or have access to them on your phone or tablet, make sure you do that. If you want to print them out and you're used to taking notes on something paper, just print them out before you come to AQO. Bring them with you so you have them. No updates from IQVIA. Here's the IQVIA support plan. They are on the phone if you have any questions. And then now I'm going to hand it over to Susan to give her presentation. Susan's a nurse at Stanford Healthcare, and she's the clinical quality analyst of the cardiovascular health. and she'll be presenting today on the development and implementation of a perfusion navigator. Susan, I'll hand it over to you.
Hey, thank you, Carol. Good afternoon. Thank you for the opportunity to share our PI project with all of you. This came about because possibly, like some of you, filling out the perfusion questions were a bit intimidating, especially for those of you who abstract in the anesthesia module. In this presentation, I will demonstrate how we went from feeling indecisive to now feeling much more confident about the accuracy of one of our perfusion-related data. Stanford Healthcare is located in Palo Alto, California. We also abstract for our Stanford Healthcare at Tri-Valley in Pleasanton. The annual STS volume in Stanford is 1,000 cases and 175 at Tri-Valley. We have 4 remote data abstractor quality analysts. We have 9 Stanford heart surgeons and 2 that work out of Tri-Valley. This all began back in July 2017, when Stanford began participating in the STS adult cardiac anesthesia module utilizing version 2.9. However, with the implementation of version 4.2.2 in 2020, came the addition of many more perfusion fields, increasing the need for more comprehensive documentation. The need for a one-stop shop perfusion document became apparent. The problem was that perfusion documentation was often missing or difficult to find, and we realized that there was a knowledge deficit by the abstractors of perfusion terminology and workflow. Before developing and implementing the perfusion navigator, we needed to identify our stakeholders. And our stakeholders are the manager of clinical operations of cardiovascular health, the perfusion lead, the STS manager, and the IT epic specialist. We needed to first identify a perfusion champion. Communication between perfusion and the abstractors is absolutely essential. First, because the abstractor education regarding perfusion workflow, but also perfusion education on the data fields needed and the definitions of those STS fields. IT developed a flow sheet where the EPIC auto-populates the fluid volume totals, and it also utilizes the EPIC timers, which are activated to enter events, recording and calculating bypass, cross-clamp time, and other times that can flow over. The benefit is that the documentation is streamlined to one location. It eliminates double charting. It's a readily accessible perfusion document. It's greatly improved the accuracy, decreases missingness of data, and definitely saves time. Now here is the perfusion intake and output. You can see in the highlighted areas, those fields that we document on the anesthesia section. And the one at the bottom, the wrap VAP, was very difficult for us to find. And so now that it's here on this page, we now know that if they use it, we can check that off. The perfusion summary shows you the temperatures, the lab values. It shows your harvest time for vein and radial artery. It has the cannulation sites. And one of the recently added additions was left heart bypass, because we were never sure when it was done, if it was done. And so now that's documented very clearly. So this has been extremely helpful for all of the abstractors for this perfusion data. The perfusion goal was to have a tool that would be able to be used for all their perfusion cases, not just those in STS. It streamlines documentation, it eliminates duplication, and because of those reasons, we got buy-in from all the perfusion staff with the goal of 100% utilization. IT collaboration is essential for implementation. and they were able to automate some of the data collection to prevent user input errors. The perfusion summary is, and the intake and output is located on one Epic screen. It is a living document which can be edited and updated as needed, and it is accessible to both our campuses at Stanford and at Tri-Valley. Next step is the continuing evaluation of this tool for effectiveness and compliance, and future consideration of mapping the appropriate fields to the STS vendor tool to decrease on abstraction time and increase accuracy of data entry. Thank you to our CVH quality team, perfusion, and Epic IT support. And thank you very much for the opportunity to share this with you. I hope it was helpful. Any questions?
Yeah, thank you, Susan. That was a great presentation. I have a couple questions for you. This is Carol. They're not hard ones, I hope.
Okay.
How much time did you save? Like, did you track the time saved by implementing this? Because it seems like you would probably be saving a ton of time and going through the chart, hunting for everything, and having it all now in one place.
That's a great question. And while we never figured it out, I'm sure it saved, I mean, it could probably have saved an hour per cut case, maybe not quite that long. We had to go through so many different documents, and there still are some paper documents in Epic. There were some that were scanned in, and trying to find things or emailing. So, you know, it could take up to an hour, you know, if things were not documented properly, which they weren't. And that was what started this whole thing.
Yeah, that's wonderful. And there's a question here from Sue Price, and I had kind of similar question. I didn't know how quite to word it. Sue says, does your facility use the Epic perfusion machines in electronic forms?
You know, I don't know that I can answer that. You mean like the machines inside the room that just transcribe the data that automatically, I know it automatically flows over from their instruments into Epic.
Oh, that's good. That's what my question was too. And I think that's kind of what, I think that's what Sue's asking. So that's really nice. And then it flows from the perfusion, from the pumps right into the, right into Epic, into the EHRs, into this form that you have built.
Yes. And that's where IT really became very helpful. And
yeah, that's so cool.
And that was the problem we had before, because we did have other documents, and when we find one place it would be in one number and another place it would be another number. So then the perfusionist would kind of give us a default, you know, you need to use this one because the other one isn't always accurate. So by having it on here, this is our default form, and that has really been a big help for not only the accuracy of the data, but because, like you said, it saves time.
Yeah. Did Epic build this, or did your IT team build the form?
I'm thinking that they had a form originally, but it didn't meet our needs. So there was, I mean, when I started here, there was a form in there. And then our Epic IT person was instrumental in actually building it. And I don't know if he went to the Epic build team, but I believe it was our IT person at Stanford.
Okay, that's phenomenal. Do you use IQVIA for data entry or a third party?
We have a third-party vendor. We use Lemet, and we're currently using Lemetics.
Okay. Did you use any Cupid capture elements for this? I'm not sure what that is. I'm not that smart, but
I'm not sure what that is either, so I'm not sure how to answer that.
I have to Google it.
Well, Cupid is I think that's Qcentric's data entry form. I think that's
we don't input directly into IQVIA. We do use vendor software.
Michelle says, nice work, thank you. Susan, and then this is from Nikolai. This says, Susan, did you have any automations from the STS software side from your database vendor? I think you still
we have.
Oh,
No, we're manually, I mean, we have our ADT that's with our vendor that's in there. And that's kind of what we're thinking of maybe in the future, of having some of those things that don't change to be automatically put in, that has not occurred yet.
Okay. Ellis says the perfusion record used at Stanford is very clear and would love that if it could be applied or implemented as a standard form for all hospitals, whether it's Epic software or not. Yeah, it's a big project to work with your IT team to get this implemented, built and implemented. Here at,
Well, you can see it took a while. I mean, we started, like I said, in 2017, and we had a change of perfusion leads. And then when we got the new one, we tried it again. And of course, IT gets backed up with other projects. So it's taken a while, but they're very receptive. And so it's nice. Like when we added the left heart bypass, our team realized that we didn't have that and could they add that? And they did. So I think, like I said, communication is key within all the team members to get it to where it is. And I'm sure it's going to continue to change, especially as STS probably will add more fields.
okay. A lot of people are responding Cupid is the heart module or the cardiac module in Epic.
Yeah, Elena or Katie, do you have any idea if we use that?
Cupid is usually used with the cath lab. I know when I was doing like VQI, we had to use Cupid to look up elements. I don't believe for a lot of the elements we use, we're using the Cupid.
Okay, thank you. Here at Salem, this is from Karen. Here at Salem Health, we made a smart tool for perfusionists. We had their buy-in and it has been really successful. So it sounds like this is has been a great idea. Has anyone tried to do something similar with capturing all of applicable risk factors for a patient, a template of some sort? Yeah, I would love to hear from anybody if you've tried to do that. Cindy Piotr is asking, and as well as Pat Hobbs is asking if you would be able to share or willing to share your template.
Sure. I mean, just what's on the screen is that, yeah, you're welcome to use that in terms of the implementation. Obviously, that's an IT, but absolutely feel free to take that and, you know, work with your hospital staff to see if they can implement something like that. I said just having everything in one place. So then if you're to get audited, you know, that's where it is.
Yeah, that's really nice. Karen says, really nice job. And then I think Hannah Whitney's responding to the risk factors, and she says she's tried, but too many sources. Yeah, I think it's really difficult to do. You're pulling it from everywhere, and if there's pre-op stuff or out of other hospital notes that you need to get risk factors from, it can be really tricky. Can you display the slide again? Is it this one?
Yeah, it's actually it's that one and then the one before that. It's two parts. It's like one big Epic screen and then there's tabs. And so, but yeah, both of those screens are all part of it.
That's really nice. Okay, I'm gonna leave that up for a few seconds. Can you share without the highlights?
Sure, I think I can.
Yeah,
I can.
would it be okay, Susan, if people were interested in it, if they reached out to you?
Absolutely.
Okay, let me put
And I have my contact information is on the last slide.
There you go. Do you plan on redoing the sheet with every upgrade?
Well, because this document is something we can edit, as long as it's something that the perfusionist can do, we can always add it. Like I said, it started with something much smaller than this, didn't look much like this one. So as long as the enhancements aren't too detailed, I would imagine that would be our goal, is to continue to keep it, you know, a fluid document.
Wonderful. Hannah says, thanks, Susan. Nice work. Cindy Piotr says, thank you. And then there was a request for this, for the second page again, so I'm showing that. Great job, thanks for sharing from Haley. Yeah, this is wonderful, Susan. Thank you so much. I knew everybody would love it. See?
Well, thank you. I appreciate it. I mean, I didn't realize it until we really got it implemented. And that's when I thought, when I first emailed Carol, I thought, you know what, this really has worked well for us. And, you know, if it can be somehow utilized within the other institutions, it's got to be a help, because we really had, all of us had difficulty with perfusion. Number one, I'm not a perfusionist and it's not my area of expertise. And so you go to the people that are, you know, you want the most accurate information from those that are putting it in.
Yeah, that's really great. I'm so grateful that you were able to share that with us today. Thank you so much. Any other
Well,
questions?
thanks for the opportunity.
Yeah, of course. Any other questions for Susan? One comment from Cindy is that she would love to attend AQO in person, but no travel allowed. And I'll miss seeing you this year, Cindy, in Rhode Island. And then Melinda, there is a question, a clinical question here. I have a question about a patient discharged on August 15th with routine meds, readmitted on August 18th with AFib with RVR, amiodarone added and continued at discharge. I'm assuming amiodarone was added at readmission, continued at discharge. Just do they add amiodarone on the cabbage discharge data collection form?
No, because the amiodarone, I'm assuming, was ordered for the AFib that was done during the readmission. So you only want to capture the discharge meds for the cabbage that the patient went home on 8/15 with.
Great. Thank you. Thanks for clarifying, Melinda.
Okay.
Great work. This is from Angela. Great work, Susan. We created a template for all our cardiac surgery during our clinical effectiveness project and use STS data elements to capture risk factors. That's really interesting, Angela. I have to look at that. Maybe, Angela, if you could email me, let me put my email up. I'd like to know more about what you've done that might be helpful to other sites as well. Here's my email. I'm working on updating a CV surgery report with much data that pulls labs from Epic, calculates the highest creatine within 48 hours post-op and highest through discharge. That's, yeah, of course you are, Hannah. You're always doing really neat things there. Yeah, I agree, Ala. I want to see what Angela, if she would be interested in presenting that. Thanks, Angela. Can you explain the COVID requirement for AQO? So COVID vaccination is required for AQO. Oh, Emily's got it. I'll let Emily answer. She's typing me.
Hi, yeah, I was just gonna put, we have some information on the website about it, and I can just read it here. STS requires that all registrants, faculty, exhibitors, guests, and STS staff be fully vaccinated. And we also will send out, we collect the vaccination documentation through, it's like a third-party vendor that we're working with. So you upload the proof of vaccination prior to in late September. So if you registered, you probably have already received a text message. It's like a text message service that'll take care of that. And then I'll go ahead and put my colleague Elisa. She is the one who handles this part. She's the meetings and conventions manager. I'll put her contact information in there.
Thanks, Emily. All right, let's see. Will you talk about cerebral perfusion for aorta surgery at AQO? I'm not sure what the presentation is going to be at AQO specifically, if it's going to include, I know it will not be just regarding cerebral perfusion, but it may contain some aspects of cerebral perfusion, which within the overall presentation. I'm not quite sure which one. Okay, well, it looks like we don't have any more questions left. We're about 30 minutes early, but that's okay. We can get 30 minutes back. Any other questions, please put them in. Otherwise, we're going to end it now. All right, well, thank you so much, Susan. Thanks, Melinda, Emily, everybody from STS IQVIA for joining. Have a great last day of summer.